Hello, my name is Mary Alman, and today I will be presenting on Leishmaniasis. So Leishmaniasis can come in three different kinds: visceral, as seen here, cutaneous, and then mucosal. Mucocutaneous is a simultaneous infection of cutaneous and mucosal leishmaniasis. Leishmaniasis is a zoonotic disease that is spread by sandflies. Sandflies are most active from dusk until dawn, so basic prevention would be stay indoors, wear long pants and long sleeves, and use insect repellents and bed nets as needed. Leishmania was named after William Leishman, seen down here. He was a doctor who served in the British Army in India, and he examined a British soldier who had died from what was then known as dum-dum fever, and he used his findings to develop one of the earliest strains of Leishmania, and he then wrote about it and published in 1903. So even though the visceral form of leishmaniasis is the second largest cause of parasitic death, number one being malaria, it is one of the more neglected diseases because it mostly affects impoverished countries. But it does affect 88 countries, mainly in the Middle East or parts of Central America, South America, Asia, Africa, or Southern Europe. The CDC says that 700,000 to 1.2 million new cases of CL arise annually, and less than 100,000 VL cases occur annually, although that is down from 400,000. The PAHO and the WHO say that globally there are more than 12 million infected people, and there are 1.9 to 1.6 million new cases of leishmaniasis each year, 20,000 to 30,000 deaths, and 350 million people at risk of infection. Okay, let's look at the life cycle of Leishmania protozoa. So a sandfly takes a blood meal, a bite out of your skin, and he injects the promastigote into your skin. The promastigotes are then phagocytized by macrophages or other types of mononuclear cell phagocytic cells such as granulocytes. The promastigotes then transform into amastigotes. A promastigote is a form of protozoa with a flagella, and an amastigote has a very, very short flagella, so it is non-motile. The amastigotes then multiply in the cells of various tissues and infect other cells. So at this point, this is kind of where it forms into visceral, cutaneous, or mucosal infection, depending upon what part of the body it infects. So then the sandfly takes a bite out of you and ingests the infected macrophages, and then the amastigotes transform into the promastigote stage in the gut of the sandfly. They divide in the gut and then migrate to the proboscis, which is this little stinger, and then it's ready to inject into the next person that it bites. So let's take a little closer look at the sandfly. So the amastigote goes into the sandfly, it goes into the midgut where it matures into it changes back into a promastigote. It then moves to the thoracic midgut where it turns into a metacyclic promastigote, which then goes to the proboscis and then goes into the mammalian host and thus infects the macrophage. So here's a picture of a promastigote and an amastigote. You can see they're pretty similar. It's a nucleus, kinetoplast, basal body, flagellar pocket. The promastigote has a long flagellum, and the amastigote has a very short little flagellum. When looking at the amastigote or promastigote under a microscope, when it's stained, you can see the nucleus and the kinetoplast in a slide that I will later show you. So let's go on to visceral, also known as Kala Azar, which is Hindi for black fever. It is usually caused by L. donovani or L. infantum. Here is a nice little picture of the L. donovani promastigotes. Patients usually become sick within 4 months to a year of when they were bitten. And so, again, referring back to that point in the cycle where it can go off to infect different parts of the body, after the mastocytes are formed and multiplied, they enter the bloodstream for visceral leishmaniasis and then reach the internal organs. Visceral leishmaniasis is the most deadly form of leishmaniasis. Symptoms of visceral leishmaniasis are fever, weight loss, spleen and liver enlargement. Here is an enlarged spleen. Here is an enlarged liver. Anemia, if you take a complete blood count, then you can see if the patient is anemic or leukopenic. If untreated, visceral leishmaniasis usually leads to death about 90 or 95% of the time. Post-Caloazar dermal leishmaniasis can appear months or years after successful treatment. It is not life-threatening, but it still causes disfiguration and is still considered a reservoir for visceral leishmaniasis. There is a large HIV co-infection rate, which causes difficulty in diagnosis and treatment. Visceral leishmaniasis, most cases occur in Brazil, East Africa, or India, as shown by this little map. Diagnosis, so you can either be diagnosed by the direct agglutination test, fast agglutination screening test, or the RK39 rapid diagnostic test. These three are all serological tests. Serological tests only work in visceral leishmaniasis. They don't work as well in cutaneous and mucosal leishmaniasis. Another test would be examination of tissue aspirate. Normally they take a sample of bone marrow and examine it for infection. They could also take part of the spleen or a part of the lymph node to examine it, although this is very risky, especially in areas that are impoverished and don't have a lot of resources, proper medical resources. Next we have cutaneous leishmaniasis, which is the most common form of leishmaniasis. It is split into two sections here. In the Western Hemisphere, or the Old World, these are the main causative species. And then in the New World, or the Eastern Hemisphere, these are the main causative species. There is a subgenus Viennea, so this is Leishmania, Viennea, Brasiliensis, etc. About 95% of cutaneous leishmaniasis cases occur in the Americas, the Mediterranean basin, the Middle East, and Central Asia. Symptoms begin within weeks to months after being bitten. Symptoms include skin lesions, ulcers, and if the skin lesions and ulcers are near the lymph nodes, then the lymph nodes will swell up. These leave lifelong scars and sometimes serious disability. Lesions typically develop around the site where the bite occurs. This is more in localized cutaneous leishmaniasis, which is normally what people are referring to when they refer to CL. But there's also a rare form of CL, which is diffuse leishmaniasis, which spreads lesions all over your body. The development of lesions, it starts out as this little papule, and then it forms into this nodular plaque, and then it usually forms into an ulcerative lesion, which is that scabbed over crater-like lesion wound that was in my first slide. Diagnosis, you normally take a tissue sample from the skin lesions. You can then stain it and use light microscopy to examine it, or you can use other molecular methods such as PCR or specialized culture techniques. Here is an example of a macrophage with little mastigotes inside. Here is the nucleus, and the black arrow points to the kinetoplast. Mucosal leishmaniasis is also known as aspundia, so instead of the mastigotes spreading into the bloodstream, as in visceral, or just staying in the skin, as in cutaneous. These actually go from the skin to the nasal or pharyngeal mucosa, which is the nose and mouth. It's usually caused by the species of the Viennea subgenus, and these are all prevalent in the New World. So mucosal leishmaniasis is restricted to the New World. Mucosal leishmaniasis usually develops within several years of the original cutaneous lesions, so adequate treatment of the original CL infection reduces the risk of developing mucosal leishmaniasis. Again, mucocutaneous leishmaniasis is those mucosal skin lesions and the cutaneous skin lesions occurring simultaneously. Initial symptoms of mucosal leishmaniasis are persistent nasal stuffiness or bleeding, and if left untreated, it can lead to destruction of the nasal or pharyngeal mucosa. For example, the perforation of the nasal septum. So a lot of times after a bad infection of ML, people have to have surgery to have their nasal passages and airways reconstructed so that they can work properly again. So the efficacy of the treatment depends on your geographical location, the type of leishmaniasis you have, and often the species of leishmaniasis that infected you. So parental therapy is when medicine is injected intravenously or intramuscularly into your body over a course of several days or weeks. In most cases for leishmaniasis, it's about 20 to 38 days, depending upon how bad your infection is. So there's amphotericin B deoxycholate, can be used to treat cutaneous and mucosal. It can be used for visceral. It is highly effective in visceral, although it is very toxic and bad for you. Lipid formulations of amphotericin B treat all three forms, and it is better tolerated by the body. Patients with co-infection of VL and HIV, in order for leishmaniasis treatment to work, they first have to undergo antiretroviral therapy, and then they can go on to receive treatment for VL. They may need higher doses or secondary prophylaxis in order for the treatment to work. There's also pentamidine isothianate, which treats all three, but it can be very toxic and varying efficacy. There's pentavalent antimonial therapy. For cutaneous and mucosal, there's no standard treatment yet, and for visceral, it is highly effective in most regions except for South Asia. Paramomycin sulfate treats visceral leishmaniasis, but it is not available in the U.S. None of these treatments are approved by the FDA, and a lot are usually bad for the body, except for the lipid formulations that is FDA approved and relatively good for you. Oral therapy, the FDA approved miltefosine in 2014 for the use of treating cutaneous leishmaniasis, although it only treats these species with varying efficacy based on your geographic location. And for treatment of VL, it only treats L-Donovani. To treat CL, and a few other pills are ketoconazole, itraconazole, and fluconazole, although none of them are FDA approved. Local therapy treatments for cutaneous leishmaniasis are cryotherapy, thermotherapy, topical application of paramomycin, and intralesional administration of antimonials. Antimonials are typically pretty toxic for the human body. One thing that I forgot to mention earlier in my video was factors that increase the risk of contracting leishmaniasis. So there's poverty, unsanitary or crowded housing, living conditions, widespread deforestation, urbanization, change in temperature, rainfall, and humidity. So more harmful and increased risk in immunosuppressed patients and people with malnutrition. Here are my references, here are my image references, and thank you so much for listening.